gastroenterologist and focused on GI conditions, but she's been using virtual reality clinically for quite some time now and accrued a really large set of experience, has a lot of wisdom to share about what works and maybe what doesn't work using virtual reality. I know we're always very excited about virtual reality, but we also have to recognize that sometimes it doesn't work. Sometimes there are side effects. So it's really important to hear these sort of first-person experiences about lessons learned using virtual reality in the clinical trenches. So I'm really excited that Linda's with us today, and take the stage. Look forward to your comments.
Okay, great. Brian, thank you again for the invitation, and Brian, thank you for setting up my talk. That means I get to spend 20 minutes talking about virtual reality instead of DGBIs. So as Brendan discussed, I'm a clinician first, I'm a clinical educator, I'm also an administrator and a clinical researcher. So these are all the hats that I wear. And so with these hats and these optics, I'll be talking about some of the benefits, but also the potential limitations. During the next 20 minutes, I'll talk to you about my journey to virtual reality. I'm not a virtualist. I am a realist, though. I think of myself as a MacGyver. So when I'm trying to solve a problem, as Brian discussed with DGBIs, there are not therapies out there. So as a realist or a MacGyver, I look around to see what potentially can solve my problem. So where's that paperclip that I can turn into a bomb? So that's me. I'm a realist. For those of you who are the developers out there, hopefully my journey will help you kind of think about how the end user or the prescriber might be thinking about virtual reality, because I'm an absolute believer in that virtual reality helps, but if it's only in the lab or if the products stay in the lab, stay in the research realm, it will not get out to the patients. So just to level set a little bit, Brian talked about DGBI. So I'm going to use DGBI and neurogastroenterology kind of interchangeably. So neurogastroenterology, neurology, and gastroenterology, the intersection of that. And again, as Brian said, the symptoms are nonspecific. There's a frequent overlap with other chronic pain disorders like fibromyalgia, chronic back pain, migraine headaches. There's a lack of objective markers, variable subjective experiences. So you may have two individuals with irritable bowel syndrome, but completely different experiences. One may be working with minimal symptoms, and somebody else may be completely debilitated and going in and out of the hospital. There's a high placebo response rate, high psychological distress, absence of a cure, and dissatisfaction with medical therapies. So this is absolutely a space where VR could fill an unmet need. And again, as a non-virtualist, the way I think about VR is that there's distraction VR, which is, where you're kind of immersive and you're looking around at the environment or swimming with dolphins, the focus shifting, so playing with games, and skill building, which you've heard about. I'm going to talk about kind of a little bit of each of these programs or different types of VR in the clinical sphere. So like I said, I am absolutely convinced that virtual reality has a place in DGBIs by tapping into that brain-gut connection. As Brian mentioned earlier, there's already IRL therapies or IRL evidence that brain-gut therapies work. So this is gut-directed hypnosis, cognitive behavioral therapy, mindfulness therapy, and this is just a meta-analysis showing that these therapies work. And when you compare, the multidisciplinary care, which does also include these gut-brain therapies, that they're more effective and they're more cost-effective. So there's still a problem, though. There's the access, right? So we have, after 3 years, hired one GI psychologist, and after being with us for 1.5 years, she now has a 6-month wait. So it's one psychologist to 51 gastroenterologists. There's the cost, right? So even if patients can get in, insurances don't cover the cost of a GI psychologist and the stigma of coming in to see a psychologist. So how did I get into the VR world? And it's really about serendipity, and this is where my mom hat comes in. Because this is now, he's 16 now, but he was 9, and I got this emergency phone call at work. It's the worst thing when you're, as a working mom, to get a call from the school. Because this is what happened. He's got a broken finger. So in the past, distraction was mom making, animals out of gloves, or you blow air into the gloves and make it into an animal, and you distract your kids. So we were in the pre-op area at the Packard, and we happened to walk by Sam Rodriguez, who's with the Chariot program, playing with virtual reality glasses. So I walked over to Sam, introduced myself, and asked if Simon could play with it. So he had these glasses on, and he was playing with space burgers. And so basically, he's just shooting at these burgers. And he got his IV, not a single tear, not a single utterance of pain or anything. And Sam Rodriguez and Tom Caruso with the Chariot team, they're anesthesiologists. And what they found was that when kids were playing games, getting procedures, they always leveled up right when the needle was going in. So that's why they decided to create these programs where there was no leveling up. It could go on forever and ever and ever. So, as the realist or MacGyver that I am, and the multitasker that I am, while Simon was getting surgery, I called Sam on over, and I said, hey, let's collaborate. So Sam, Tom, myself, and Anna Varen, who's a pediatric GI psychologist, we said, VR, awesome. Mindfulness, great. Can we put them together? So this was back in this was 2018, so we had the Oculus headset with the Galaxy 8 phone, so we were one generation behind you, Brennan. And we created this experience. And so we hired a programmer to help us create this experience. And I love the Aurora Borealis. So I was like, please send me to the Aurora Borealis. Create something like that. So you start there with seeing these butterflies, and then it kind of transitions into this Aurora Borealis. And as you're transitioning, the meditation talks about the coolness, so the burning pain kind of gets cooled down. And what we also did was that the butterfly, the aurora, and you don't really see it here, but you can actually see the breath come out. And it slows down as you go through the program. So it's a 6 and 10 minute program. So we had 2. And what I thought was really interesting was, even though I helped create this program, when I put it on and I saw the breath, I knew it wasn't my breath, but my breathing rate continued to sync with it, no matter how slow or how fast we programmed it. So after we developed the program, we decided to beta test it before investing further. So the way we did it was that the patients were coming into my clinic, so busy, I see patients every 30 minutes, and when I was done seeing them, they were offered virtual reality, and they could choose 6 or 10 minutes. It really depended on how much time they had, and unfortunately, we just used the clinic room. And these are the results. We had 63 patients with chronic abdominal pain. And again, we took everybody who came, so these were the different diagnoses that they had. And we use a numeric rating scale, so 0 to 10 scale for pain and anxiety. And we found that over 60% of patients had a 1-point reduction in their pain scale, and a third of patients had a 2-point reduction in their pain scale. And you see the pre and post, both pain and anxiety improved. And Anna, being a pediatric GI psychologist, she works with our inflammatory bowel disease group. So she took this over to her clinic, and she worked with teenagers, thinking that young kids would not really understand mindfulness. So she worked with teens. So the mean age was 15, And she used a different pain scale and different anxiety scale, but you see here there was a reduction in the pain. And then asking these teens if they enjoyed it, most of the teens enjoyed the experience and they felt more relaxed. And these are patients with Crohn's and inflammatory bowel disease. And I'm going to tell you some stories. So you see the data. I'm going to tell you some stories about actual patients. So Serena has irritable bowel syndrome with diarrhea, and she's had symptoms for more than 20 years, multiple emergency room visits, isolated. I mean, she's had tons of testing, and I've had multiple conversations with her about the, brain-gut interaction, tried to get her to see a GI psychologist, and she absolutely refused. And then I had her try the VR glasses, and she had that aha moment, Brennan, where she was like, oh my gosh, I feel better, and I can't believe how much more relaxed I feel, and I didn't realize how tense I was. Now Serena was interesting because she had this bubbly personality, but she could also be very hard hitting. But she got along with Mallory, my nurse. So she convinced Mallory to let her come in every week just to do virtual reality. I don't know how long Serena ended up doing this. I think it was for a couple of months. She came in once a week. And to this day, now about 5 years later, she doesn't use virtual reality anymore. But every time she has a stressful event and her IBS symptoms flares up, she recognizes how stress affects her gut, and she starts to do meditation and abdominal breathing. And she hasn't been to the emergency department. She doesn't really need me anymore, but she still comes to see me once a year just in case she needs me. Those are actually the best appointments because we go in and we chit-chat. Now, Rachel also has IBS, but she has the constipation type. But in terms of the other impact, very similar to Serena. Offered virtual reality for her, and next thing I hear the door slamming open, and she just ran out. We chased after her, and the virtual reality glasses induced a panic attack and PTSD. And her comments were she felt anxiety, worry, self-conscious, this overwhelming need to cry, and she just couldn't blink it back. And she literally ripped off the glasses and she ran out the door. We could not, I had to call her because I couldn't chase after her. So some of the limitations of VR is that we've heard all the positive experiences, but it's not universal. And you can see each of those dots represent one patient. And majority of the patients you see that there is an improvement in their symptoms, but there are 3 patients here where their pain got worse and their anxiety got worse. Not the same patients, but there's some who had worsening pain, some had worsening anxiety. We did have some cyber sickness and migraine. The cyber sickness was not actually just one patient, and a couple patients had kind of a flare of their migraines. The other things when we talked to the patients afterwards, one of the things that we learned was you have to immerse all the senses. So this was back in 2018 that we started doing this, and we didn't have the noise canceling headsets, and so they were just sitting in our exam room, and you could hear it, and then they could hear all the noise outside, so it was distracting. And it was Anava's voice who was doing the meditation, and she does this all the time, but she's not a professional in terms of recording. And a few patients thought that her voice was too young for this. And for some, their breathing rate was mismatched with what we had programmed in. So again, they had a hard time focusing because of the mismatch. And then there was the limitations of the cost. So, this was funded by a grant from essentially a gift from a donor. And so, oops, I'm going back. So we had about $10,000 to do this. And so the question was, before we decided to go further, do we need the mindfulness meditation, or can distraction work? So again, what we did was we had patients who came into the office, and we kind of randomized them to either skill building, which was our Med Mindfulness program, versus distraction, which was swimming with the dolphins. And we had, I think, 64 patients in the whole series, with half in each of the arms. And you see here that pre and post, both groups had an improvement, but there's no difference. There was no difference between the Med Mindfulness versus the distraction. So the question is for kind of acute use, do you need mindfulness, or is distraction enough? What about long term? And that's what we don't know yet. And this study is actually Eve's study here. Eve is one of our nurse practitioners on the inpatient side, so the patients who are really at the worst of the worst, who are in the hospital. And Eve is doing her doctorate thesis, and so she used virtual reality. And she looked at virtual reality in patients in the inpatient setting, and you see here, oops, I keep doing that. And these are each individual patients that there was a reduction in their pain scores. And this wasn't Eve's study, but this was back in the day when I was doing inpatient medicine. Melissa was a patient who has gastroparesis and centrally mediated abdominal pain syndrome that Brian talked about. And she was in the hospital a lot. She was always in the hospital. She always needed her IV dilaudid, and she was on a schedule, and she just watched the clock. I mean, she watched the clock. When it was 5 minutes until when she needed it, she would push the button and call the nurse to come in to get her dilaudid. And the nurses thought she was angry and difficult, and she just spent all her day in bed watching the clock for her dilaudid. I see Brian nodding because he's taking care of patients like Melissa. So this is back when we were using the Oculus. I just handed her the headset, left it at the bedside, and said, whenever you have pain, instead of relying on the dilaudid, try the headset first. And she ended up using it 2 to 4 times a day, and during that hospitalization, she did require less dilaudid. And you know, she said that she was able to relax more, feel less anxious. She was able to take the focus off her pain, and she was no longer just, you know, hypervigilantly staring at the clock. Now, did she become, you know, warm and fuzzy and all the nurses loved her? Absolutely not. And did that cure her pain and she never went back in the hospital? Absolutely not. But what it did was that it gave her another tool. It gave us another tool to help her while she was in the hospital, and that she wasn't always stuck in bed. So other things I think about are sort of how do we get VR out to the patients? So there are now free apps, subscription, prescription, things you can do in the clinic, home-based. The problem that I see, and when I try to recommend virtual reality to patients, is one, when there's too much on the menu, it's overwhelming. They don't know where to start. All right, so I give them a list, try this, and majority of patients will not try it. One, because it requires an investment in money. Even the ones who've tried it in the clinic and have felt an improvement, investing in the several $100s to purchase the device, it creates an inertia. I think I've had, of all the recommendations I've made, I've had maybe 2 patients purchase a headset. And so unlike in the research study, I wish I could send and ship out the headsets to patients. The other issue is that, you know, with telemedicine, fewer patients are coming into the clinic. It's just so much more convenient to do it virtually. So now they're not coming into the clinic for me to say, try this. So now it's even harder to convince someone to purchase the virtual reality glasses because they are not yet convinced that it will work. Brennan already talked about this, and also Brian, but one of the things that I think is interesting and we have to kind of look at in the future is whether disease-specific VR is better than kind of more non-specific VR. And one of the key things about the CEDARS program here is the education piece. One of the things I did not mention earlier is that for every single patient that I offered virtual reality to, I educated them about the potential benefits. So it wasn't just, here are the glasses, go. It's, here's the glasses, this is why it would help you. This is the brain-gut connection. So what Brennan's doing here is including the education piece in the program. And truly, education is the most powerful weapon which we can use to change the world. And I encourage all you who are developing programs to make sure that you include education in any part of your program. And so things to consider in the future for pain in terms of VR-specific factors is distraction, focus shifting, or skill building, better, equivalent, doesn't matter. Generalized pain or something more non-specific versus disease-specific. Which are the appropriate patients? How often, how long do we need to do this for? What's the durability of response in terms of acute versus chronic pain? And some of the implementation factors that I talked about, the cost. What's the reimbursement model? What's the insurance coverage? Space utilization. That's my administrator hat. If someone's sitting in one of my exam rooms for 15 minutes, I can't use that exam room for something else, right? Not for another patient, not for another procedure. Integration into an evolving clinical practice in the era of telemedicine, and then infection control, right? So how do we, disinfect these devices? And when I think about how I position virtual reality in my patients, in those with mild symptoms, I think of VRX as education and treatment as needed. So go into the kind of your urgent care or treatment room and do just treatment as needed. For those with moderate symptoms, it can help augment medications. For those with severe symptoms, I don't think that virtual reality alone will work, but it may help augment the multidisciplinary therapy. So they may go see a GI psychologist or a pain psychologist, but in between appointments, work on a virtual reality meditation program. So as many of you know, chronic pain affects approximately 1.5 billion people globally. I'm going to say that again, 1.5 billion with a B. And so if one is lucky, a solitary fantasy can transform 1 million realities. And I'm hoping that virtual reality can at least have some impact on the lives of those 1.5 billion people. So thank you.
What a great talk. One great talk after another. That was amazing. A lot to learn there.